colleague, Professor Reena Shah, and I will lead off with the first question. So, Reena, what is COVID-19?
Good afternoon, Alex, and thank you for asking me to come and join you this afternoon. And thank you to the audience for tuning in to listen to us. So COVID-19, as we all know, in December 2019, there was a new virus that was found in Wuhan in China called the SARS coronavirus 2, which stands for severe acute respiratory distress syndrome by coronavirus 2. And that's a virus that came from animals and infected a human. When this virus infects a human, the disease the human gets is called COVID-19. So coronavirus disease that was found in 2019. So that is what COVID-19 means, an infection with the SARS coronavirus 2.
So we shouldn't assume that there was COVID-1 to COVID-19, and this is like a COVID series, like the way they do the TV stuff. No. Okay, so the next question really is, how did the jump happen? We know that this corona group of viruses kind of come from the bats, and there's an intermediate host before it comes to humans. Do we really understand how it basically made the jump from the bat to something else and then to humans?
Yeah, so like I said, the coronavirus is a zoonotic, what we say zoonotic viruses. That means they come from animals. So as the population has increased, as the human population has increased, we interact a lot more with animals than we used to in the past. So it is believed that it came from a wild animal market in Wuhan. And the theory is that there was an infected animal there that infected another human that went on to infect other humans. That is the current theory. Of course, there are lots of other things going around in WhatsApp, but in the scientific community, that's what we believe. Having said that, coronaviruses have been around. So there are 4 coronaviruses that we know that cause a common cold in people. So we could all have been infected with one of the other coronaviruses and not have had any symptoms since. And just to add, the reason it's called corona. Corona means crown. And we look at the virus under a microscope. It has spikes, which look like a crown. So that's where the name corona comes from. So they've been with us for a while, but these coronavirus now and the 2 that we had, so since the turn of the century, we've had 3 pandemics with coronaviruses. First was the SARS-CoV-1 in around 2003. Then we had the MERS, which came from Saudi Arabia in 2013, and now there's 2019. So they've been around. It's just that now they're getting more and more severe as they're evolving.
So this is certainly not the last one.
Certainly not the last one, yes.
Okay, so the second question is, what really makes this COVID-19 a global pandemic? We had SARS and MERS, and it looks like people have forgotten about those. We don't remember shutdowns, we don't remember extreme measures, we don't remember extreme infections, we don't remember an animated global conversation about these previous coronaviruses. Why is this such a virulent virus?
So a pandemic is when an epidemic is in 2 continents. So when you have epidemics in 2 continents, it's called a pandemic. So the SARS-CoV-2 was called a pandemic after Asia and Europe was infected. And that's when the WHO came and said it's a pandemic. The SARS-CoV-1, which happened in around 2003, only affected Asia. It was an epidemic only in Asia. And the MERS was only in the Middle East. I mean there were a few infections elsewhere, but in terms of epidemic, those are the 2 main areas where it was. SARS-CoV-1 and MERS is more infectious in terms of your mortality. So if you get infected with SARS-CoV-1 and MERS, your case fatality rate is much higher. So they say for SARS-CoV-1 is about 10%, for MERS it's 30%. But in terms of infectiousness, the ability of it to be transmitted from one human to the other, SARS-CoV-2 is more infectious, even though the case fatality rate is lower. So they say about 3% of people with SARS-CoV-2 of the COVID-19 will die. The rest will be okay. But because it's so infectious, it's gotten to more people, more of the population than the other 2 coronaviruses. So the thing with SARS-CoV-2 is it's more infectious. They say for every individual infected, it can infect 3 to 5 others. So the infectiousness is higher, even though the case fatality rate is lower. But because they're infecting more people are likely to die. The other thing, global travel, people, the globalization, people living together, and of course social media. People know more about it. We didn't know so much about SARS-CoV-1, even though we lived at that time. Yeah.
One of the other things that is kind of driving a lot of curious conversations is, for instance, why asymptomatic people can actually transmit the disease, that they can infect other people. This is very different from other viral infections like Ebola, for instance, where people had to be really, really, really sick before they could actually even transmit the disease. So why is this, and this is probably what even makes it even more infectious, that in the part of the serial interval, within 5 to 7 days, I can infect someone and yet I'm still asymptomatic.
You're absolutely right. So we say the incubation period for SARS-CoV-2 is 2 to 14 days.
Yeah.
So from the time I will incubate that virus, in that time I may not be so unwell. I may have a mild cough or cold, and I'll go to work. We've all done that, right? When we have mild disease, we go to work, and we end up infecting the people around us. So it's a very infectious virus. And the main thing is when infectiveness is from person to person. So if I cough and sneeze, and you're within a meter distance, you inhale my droplets, and the infection you get infected.
Yeah.
The other thing we've learned about this virus is if I cough and the big droplets fall on surfaces, if anybody touches the surface and then touches part of their body, and it goes into their mouth or their nose, they're more likely to get infected. So hence we say wash your hands and keep the social distancing.
Yeah. So we said at the very beginning that this is SARS-CoV-2. It is a severe acute respiratory syndrome. Now that suggests that there's no particular symptom associated with this infection from SARS-CoV-2 virus. So what really is the disease? What is COVID disease? How do you know I have COVID disease and I have nothing else when it's multiple kinds of symptoms that come together?
So, you're absolutely correct. So if you were 6 months ago, if you got a cough and a cold and you came to see me, Alex, I would say, it's fine, just go home, take some hot water, lemon honey, or whatever your social tells you to take. Now we're like, oh, it could be COVID. So there is nothing that says this is COVID-19. It's because we're living in this time where patients are presenting with its symptoms. And the symptoms we're looking at is things like cough, shortness of breath, fever, change of smell. So there's a whole, and if you've had contact with somebody, you come from an area that is infected, that tells us it's likely to be COVID-19. Of course, there's still a lot more people who have the same symptoms, and we're just treating them as normal cough and cold or flu.
Yeah.
That's after testing them.
Yeah. So one of the things that has been said about the transmission, which is also informing a lot of the non-pharmaceutical interventions like face masks and all of that, is, and we talked about this at the very beginning, respiratory droplets, and how these are pushed out of a respiratory system either through a cough or a sneeze. And we've talked about the travel distance of these. We talked about 12 feet, for instance, and there's been interesting simulations in laboratories to suggest and to show how these might be transmitted. Now, okay, talk to us about what kinds of situations does the infection really happen in? We talk about social distancing. There's a study that just came out of South Korea from a call center, and they show in blue bubbles where all the infected people were sitting, and they show a floor in the same building, and there was no infection where there's sufficient social distancing. Like for instance, in this floor at GSMC 9 West, this is floor number 7. There could be people infected here. The next floor, if there's no one person infected, it doesn't happen. But it seems like in ordinary conversation, people are now led to believe that there will be droplets floating out in the air, and you're just waiting for a nose to inhale them. So talk to us about the transmission of this and how some of the non-pharmaceutical interventions like face masks and social distancing can help kind of break the spread of this disease.
So if somebody's infected and they were to cough or sneeze, there are droplets that come out. There are big droplets and the small droplets. So the big droplets cannot go a huge distance. They'll fall. The small can go, but we know that the furthest they can go is 1 or 2 meters. So that's why the social distancing of 1 meter, that even if I was to sit here and cough and I had COVID-19, you're not going to get it because you are that much further away from me. Now, if I were to wear a face mask and cough, yeah, unlikely to go to somebody. Yeah, it's not 100% safe because there are different types of face masks. There's the cloth face mask, there's a surgical mask, and then there's the N95, and the protection is increasing with each. But there's still protection, right? So for normal people who are not working in healthcare facilities, the normal masks are enough. But if I were to cough, the distance for the infected droplet to go is not there; it stops there.
Yeah.
So those are the reasons for the face mask coming in. We in the hospital wear an N95 because we are exposed to a lot of patients with this, rather than one-off. And when we're going to the patient, we're doing procedures on them. We will be putting a tube into their mouth. We would be doing respiratory toileting, cleaning the respiratory tract. So we have to wear that much higher protection than just you and me sitting in a room. So that's why there's a great gradation of what we call PPE.
Yeah.
If I were to cough and not cover my mouth, the droplets would fall on the desks and on the floor.
Yeah.
That's why all the disinfection has come in by the government. You know, you must clean your surfaces. If you're infected at home, your room must be cleaned very well. People shouldn't touch things. So that's why the hand washing and the disinfection has come. Because if you touch something and you touch your eyes or your mouth, it's going to go into your respiratory tract.
Yeah, some of the studies that I've read suggest that we touch our faces almost like 22 times.
Yes. I'm constantly trying not to do that.
So we, you know, it's an instinct that we've gotten, that we don't even think about. It's involuntary. So across the world, I'm talking about places like Italy, China. We've now seen the United States. There are different patterns of morbidity and mortality, and what I want to find out with this discussion is, are there groups that are susceptible to the virus and why? So in Lombardy, for instance, the average age or median age was about 79. We're now seeing a very interesting demographic structure in the United States with young adults, middle-aged people, 30 to 45. In China, it was mainly around people who were smoking. In Africa, I don't know what we're looking at, so you may want to speak to that. And so I repeat the question, are there groups that are susceptible to this infection as we see the different demographic, different patterns of morbidity and mortality? And why, if there is a pattern such as what we're trying to observe now?
So Alex, definitely we know that the elderly and patients with comorbid conditions such as diabetes, heart failure, kidney disease are more likely to get the disease and more likely to get the severe form of the disease.
Yeah.
So everyone may get COVID-19, but the ones with these comorbidities get severe and end up in hospital, either in the wards or in ICU. So that's one. Having said that, there are reports of all age groups getting infected and deaths from all age groups. But if we look at the total amount of deaths, they're higher in the elderly and comorbids, but I don't think it's left any age group from suffering from the disease. Even in the younger age group, there are people who have comorbid conditions who get affected.
Yeah.
The question that I get asked very commonly is, what about our HIV population in sub-Saharan Africa? And that's a space we're looking out for. We don't know yet because the other countries that have had the mature epidemics have not had HIV epidemics there as well. But in sub-Saharan Africa, that's something we were already grappling with before COVID-19 came. So I think we're watching that space. So far, we've not seen any evidence that the HIV population is more susceptible, but we haven't had that many cases. So I think in a couple of months, we'll be able to answer that.
Because that was one of the very, very early predictions when the first cases were identified in Africa. And everybody thought that we have such a huge reservoir of HIV, sick people, tuberculosis. People talked about malnutrition and all kinds of things. And we're not seeing that playing into the infections right now as some kind of a predisposition to this infection. But you're saying that this is not, the pandemic is not mature here yet in terms of the scale of infections.
Yes.
But what are we seeing in North America, for instance? Are we seeing huge patterns that relate to the obesity structure in the population, for instance? We've now had very interesting anecdotes about the COVID for the COVID for the wealthy and COVID for the poor. That there is somehow some bifurcation that is economic that is going on in these populations.
And especially in the US, you're right, because a lot of the African Americans, their outcomes are not as good as the Caucasians. So we're seeing that from the US, that is happening. We're watching that space yet here. We don't know yet. I think majority of our patients have done well. We're having good recoveries. We have the data every day. And if we look at the global data, Alex, there have been 3 million infected, almost 1 million have recovered, and 200,000 deaths. So that's where we are globally. And I think our Kenyan figures following that in terms of deaths and recovery, I think we're not much different from that. Having said that, I think the African countries did one thing right. They started the social distancing at the right time. I must commend the government for doing that. I know there have been inconveniences to people, but I think probably we did. And I think if I look at the US, I think they're a bit too. Italy, the reason they've had such a huge number of deaths is one of the reasons is they have an elderly population, and then they have old people's homes. So the mistake they made is in their mildly symptomatic population with COVID, they send them back to the old care homes. So they ended up infecting the others. So I think that was one mistake that they did make.
Yeah. So when we look at these epidemiological structures, some of the two driving parameters are usually your series interval and your reproductive number. So are you suggesting that some of the early measures that we took with social distancing, physical distancing, isolation, these curfews and all of that have basically made it such that these are not the critical driving factors, that our reproductive number is perhaps not what we've seen in China in the early phase of the pandemic, not what we've seen in the United States in the early phases, or not what we saw in Italy. So have these measures, can we say, still maybe early days, but can we say that this is probably some light at the end of the tunnel?
I hope so. Fingers crossed. Really hope that this is, if we continue at the level we're at, getting this less than 10, 10, 15 cases a day, I think we'll be able to handle the pandemic. What we don't want is to suddenly get 1,000 patients a day, and then our healthcare systems cannot cope. So I think these measures have helped. I see that from today, I think restaurants and stuff are opening. So we're like on the watch out as healthcare workers to see what's going to happen with that.
Okay, so the next set of conversations is going to be that this is a viral respiratory illness. So what exactly does it do when the virus gets into our body? Can you please talk us through what in your language is pathophysiology of the disease, but boil it down to the layman terms. When the virus gets into your respiratory system, where does it go and what does it do from there?
Okay, so it's a respiratory virus. It attacks your respiratory tract, and you must imagine your respiratory tract to start from your nose all the way to your lungs. It's called an epithelium. Nose is continuous to your lung. So when you inhale the virus, it enters your respiratory cells through receptors called the ACE inhibitor receptor. It enters through that, and it infects the cell. Now, what does the virus want to do? It wants to go into the cell, reproduce, produce babies that go out, infect more cells, reproduce, go out. So we call that the viral load. It keeps multiplying in your respiratory tract. And that's what causes the symptoms, your nasal congestion, you're feeling unwell because it's using your body's energy, it's using your body's cells. It's using the machine, your nucleus, which is your body's machinery. It's using that to reproduce itself. So that's why you feel tired and unwell. And your nose is blocked and you feel all those nasal symptoms. Yeah. And then it goes down to your lungs. Yeah. At the same time, two things happen. Your body produces enough immunity to fight the virus and you get better. Yeah. Or the virus overwhelms the immunity and you get worse. And it goes into your lungs, you can't breathe, your oxygen requirements go up, and you need going into the ICU and be ventilated. So one of two things can happen. Either, and it's a battle between your body's immune system and the virus.
Yeah. So linked to that is why we have these differences that range from uncomplicated mild illnesses to complicated illnesses that come out of COVID. And it's the same people. You talked about some of the complicating comorbids, but just talk us through, what is an uncomplicated illness from COVID? And what we know from some of the global numbers that 80% of the people won't even need hospitalization for intensive care. There's a 20%, then another small fraction goes into ventilators. Their fate is probably not as great. So what is the range? What is an uncomplicated to complicated illness that would then lead us to intensive care requirements?
So the uncomplicated coronavirus infection, think of it as like the normal flu we get every year, every 2 years. So you feel unwell, you're tired, you have a bit of malaise, your nose, you have a bit of a cough, a bit of fever, but you recover from it within 3 to 5 days, and you're okay. So that's the uncomplicated. It may be a bit longer, maybe 5 days could even be 2 weeks, but you're not ill enough to require hospital. The moderate, we call the moderate disease, is when your body cannot maintain its oxygenation. So you end up needing to go to a hospital to supplement your oxygen. So you get short of breath. And we tell our patients, take a deep breath in and count till 10. You take 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. If you can do that, your lungs are okay. But a lot of these patients at home cannot do that. That's your first sign of saying you need oxygen. You're not able to do that. So at that point, you go into hospital. And we measure what we call your oxygen saturation. Should be above 90%, 92 preferably. If it's not, then we put you on supplemental oxygen. So out of 80% don't come to hospital. Out of the ones that come to hospital, 15% we manage on the wards with supplemental oxygen. They may need a bit of fluids. We maintain their kidneys. There's 5% that need to go into the intensive care unit and be ventilated, and we put on all these machines.
Yeah, so that's a good point to get to the next point, the next question. There is no cure for COVID-19.
Correct.
What then do we do with patients who come to the hospital who have COVID-19?
So the ones that are in the ward, we just give them oxygen, what we call standard of care, which is without medication, all the other things they need. So a patient needs oxygen, they may need food, they may need fluids, we support all that, right?
Yeah.
So that is what we call standard of care.
Yeah.
There are some medicines, but we don't know if they work, because remember, the virus has only been around for 4 months. I mean, this is the 5th month. So there's not enough trials that are done. Usually trials are huge number of patients done over 96 weeks, 180 weeks. So we've not had the luxury of that time. So we have small studies that say, this drug has been used, this drug has been used, use this drug. And it's all over social media. Yes. There are about more than 500 publications since January on this. So even keeping up with this. So that's when we decide what we're going to do with these patients. Yeah. There's a big trial that the WHO is doing called the Solidarity trial, which is looking at patients, so randomizing them into, so any patient that comes in is given a number. It's a random allocation. They'll be put on certain medications to look at the outcome.
Yeah. So this is interesting because there's a lot of publications out there, as you've pointed out, that are trying different kinds of medicines. And some of them are proceeding from the assumption that this is a viral infection. So any broad spectrum antiviral medicine should take care of something that relates to the virus's activity inside the pneumocyte cell in the lung. Some of these range from drugs that may inhibit the lodging of the virus on the cell through the ACE2 receptor. Some relate to the phases of the virus where it produces its RNA strand, and some relate to kind of constituting the various elements of the drug of the virus that then creates the crown, the capsid, and all of that. So there's a lot of conversation around looking at the various stages of the viral multiplication, and there's even drugs that then take care of the body's excessive immune response.
Correct.
That then creates further complications. So we're not necessarily groping in the dark. We are onto something here. So what is your experience with some of what's working from some of the work that you've done, from your conversations with colleagues? Where are the spaces where we're seeing some interesting progress, even though we have not instituted full clinical trials, but just doctors from their experience and out of the passion and the commitment to support patients and basically saying we're going to throw everything at them because the the outcome of not doing anything is fatal.
So, so there is a lot of experience out there. So we in the infectious disease world, we network,
Yeah.
right? So whenever we have a very sick patient, what we try and do is speak to colleagues abroad and say, what can we use? So the things that, so this is now talking about end stage patients who are terminal in ICU, because we know for the 80% who are going to do well are okay, and the 15% who are in the ward, we know if we just support them, they'll be fine. These are the ones that deteriorate. The two things that seem to be working now are what we call convalescent plasma. So convalescent plasma, and this is something it's not been used in Kenya yet. It's something we're looking on doing once we get the ethical approval. So what they do is you take the blood of somebody who's recovered from COVID-19. And we know once you recover from COVID-19, you have antibodies.
Yeah.
So we take the blood and we spin it, and we take out the blood that's called the plasma. We keep it, and then the next patient who's very sick in ICU, if they match, because blood has to have a donor and there's to be donor recipient matching. Once that match, that is given to the recipient. But like I said, that's again in trials and we haven't done it here. So that's one, and there's enough evidence from abroad that it may work. It's being used, we call it convalescent plasma. It was used in First World War for the soldiers. The soldiers went to fight with it, and they would get infected, and it was given to them. It's being used in Ebola. It's being used in SARS-CoV-1 and MERS, and they've shown benefit there. So we're hoping that's going to be the same here. The second thing that we've used is what we call monoclonal antibodies. When patients go into ICU, one of the things that kills them is their own body's overimmunity, if I may say, what we call a cytokine storm. When the body produces a lot of cytokines and then the patient deteriorates. At that point, there's evidence that if you can give this monoclonal antibodies, which are used for other conditions such as SLE, rheumatoid arthritis in severe forms, if you give it, it reduces that. That we have used, and we've had a good outcome in the hospital. And there are other centers that have used it as well. So those are the options that are there.
So my sense from just what you've said is it's really as kind of going much deeper into understanding the human body and understanding the viral replication pathways and trying to figure out, in the arsenal of drug therapies, what would be some of the best matches. But as you know, the outcomes have been uneven.
Yes.
And again, it depends on the patient, the age, what are the comorbidities they have, and all of that. And one of the ones that Donald Trump has been promoting, which is now becoming extremely problematic, is hydroxychloroquine, which initially started off as pretty promising, but some of the work that I've seen is that 27% of patients who got the drug died, compared to 17% of patients who did not take the drug. So are we now closing the door on hydroxychloroquine?
So it just, in addition to that, the study that made Trump say what he did was a very small study. Only 26 patients were given hydroxychloroquine.
Yeah.
So in the whole study, there were 46 patients. 26 were given hydroxychloroquine, 20 were not given that. Out of 26, 6 dropped out. Yeah. And the 6 that dropped out had 3 deaths. 2 went to ICU and 1 reacted to it. So I'm like, that's a huge number not to include in the final analysis. Yeah. So I think in the medical community, we found that this trial was flawed. So we didn't buy the hydroxychloroquine thing, and we're not using it anymore. Yes. Having said that, the WHO, the trial I mentioned, is going to look at it. So they're going to have one arm is going to be given hydroxychloroquine to see if there's any benefit. Yeah. Sometimes, when patients are recovering, it's like we took all our patients who had URTI and gave them all an antibiotic. 80% will do well. Is that because of the body's immunity? Is it because of the drug? So you have to have a huge numbers to say this medication works. But for the critically ill, so I think for the mild to moderate cases, we can wait for the trials. What we're struggling with now is the critically ill, and we're trying to give them, because we don't have time. Time is not on our side. Those are the patients, and we make a call to give something. Of course, we discuss it with the family. There's ethics, there's all ethical consent. Everything is gotten from the family before we give any of these drugs.
So one of the other theories out there is that, and I checked this with a friend of mine that I was speaking with who lives in Portugal, and says that Portugal is one of the very few European countries and some parts of Netherlands that had continued the practice of the vaccine BCG. And in those countries, they seem to find that the cases have not spiraled as much as they have spiraled in countries that stopped using BCG many years ago. Africa is one of the continents that has intensely promoted the BCG vaccine. And I've heard that one of the kind of initial explorations around vaccine for COVID-19 is BCG as a basis for developing a stable vaccine to go against this disease. You know, what are some of your, what do you think as somebody who lives this kind of life like every single day?
So to be honest, I don't know whether we're going to have a benefit with BCG and COVID-19. That one I don't know. And I really hope for our population that it's a true thing, because we're all vaccinated against BCG. We all probably had it 3 or 4 times when we were in school here. So I do hope that it works, but we're still waiting for the scientific evidence to it. The only thing is, when I speak to my colleagues in England, they say that a lot of their population who's dying is the 80, 90-year-old population who got BCG vaccine before England stopped giving it. So we don't know. I mean, that's a thing we're waiting for. Talking about the vaccine trial, it started in Oxford 2 to 3 days ago. Very neat study.
From the Jenner Institute,
Yes. Very neat study. Looks so, like I said, the coronavirus has those spikes that make it look like a crown. So they've taken part of the spike, and that is what, and they've engineered it, and that's what is going to be. So it's a dead virus. They're taking a part of it. They're not injecting a live virus. So they're just taking the spike, putting it into humans to see if you produce antibodies to the spike, and it can protect you. And then, so there are 2 groups. One group is having the vaccine. One group is having a meningitis vaccine, and they're going to watch them over the next few years to see if the population that was vaccinated will get the infection. Of course, we know vaccine studies, will have the result. It'll take years for us to know whether it works or not.
Well, some of the claims that I've read suggest that we'll have a vaccine as early as September. Others are saying we have 12 to 18 months to get a vaccine. So in the absence of cure and some transmission of this disease going on in the population, we have seen that you cannot really stamp it out. Even in Wuhan, there's still some resurgence. We've been seeing some numbers. Singapore now is going back to lockdown. We've seen some small surges in South Korea, for instance. Right. And in the United States, Dr. Fauci is basically saying that there will be a resurgence in the winter. Right. So what are we looking at? Are we going to say, let people just go out there, get the disease, and we approach some kind of herd immunity as we wait for a vaccine? Or what are we going to do? As in the absence of any cure, I think the only other way is that people just get inoculated by the disease themselves, and then we see who survives and who dies.
So we still don't know whether herd immunity or whether immunity from COVID-19 protects you. So if we just take a step back, if you had chickenpox as a child, and a lot of us did, you will not get chickenpox as an adult unless your immunity goes down. So we know that the chickenpox antibody protects you from getting chickenpox. HIV is the opposite. You can have HIV disease and you have HIV antibodies. So the HIV antibody is not protect you against HIV. We are watching the space of COVID-19. We don't know whether it's protective, how protective it is, and for how long to protect it. We don't know.
So right now, we should just encourage the governments to institute lockdown measures. We should go to non-pharmaceutical interventions. We should maintain the social distance.
For now, I mean, we haven't had complete lockdown in Kenya. We've had quarantine and isolation. I think that's a good approach for now until we know better. I mean, we will be getting studies as they come out, which will tell us how effective the antibodies are. And talking about vaccine, if we look at all the vaccines, the best vaccines have been vaccines against viruses. So again, like things like hepatitis B. Then there's some good vaccines against bacteria, such as meningitis. So I'm hopeful, because the virus is so small, it's easy to get a vaccine against it. So there is hope in the infectious disease community that if we do, we will get one. Having said that, the influenza vaccine only works for 1 year. Every year you've got to get a new vaccine. So we're just again watching the space for the coronavirus.
Okay, thank you very much, Reena. So that's the end of this first segment. So we'll now take your questions. So we have a lot of questions for you, Reena. We have 12 questions so far.
Actually 20.
The 20 questions. We'll start. So thank you very much, colleagues out there who are listening. We are glad to take your questions, and I'll run through them as quickly as we can. So here's a question from Uganda. Hello, doctor. In Uganda, the Ministry of Health confirmed cases of COVID-19 from truck drivers who are asymptomatic entering the country. Now, how can we screen out those persons if tests are not taken?
That's very difficult. I mean, you do the normal, symptom screen and fever, but if you're asymptomatic, that's a tough one. And I think that's one thing we're beginning to learn, that people who are asymptomatic are also transmitting. So that's something we need to watch. I saw that there was a 3-kilometer, I don't know, in Malaga, there were all the trucks in Malaba, all the trucks waiting to get tested. So these are difficult decisions that the ministry have to make, but they have to test them to know that they're negative. There's no other way about it.
Yes, and then the other question is, how has attention to other major illnesses like cancer been affected by this COVID pandemic? Have we lost all attention and dedicated all the resources to this new kid on the block? If this is a new shiny toy, as some people may call it.
That's such a good question. I tell you, we're worried at the hospital what's going to happen to our. So a lot of patients are not coming for care now, whether it's because they can't move from county to county, whether it's difficult, whether and they're scared. People are scared to come to hospitals. But having said that, I must say all hospitals have instituted good infection control. So even if you go to a hospital, don't worry that we will leave our COVID patients outside. They're all in one place. You can easily go to the cancer center.
So why has this disease been stigmatized even by health providers?
I think healthcare providers are scared. Initially, they're scared. All these things coming from Italy, that so many doctors died and so many nurses died. But as long as you wear the right gear, you're okay. Right? And we in the Frontline, we've done it. So I think the doctors and nurses in the Frontline don't have as much stigma as those that are not.
So the main complication of COVID is respiratory distress. What are your thoughts regarding cardiac injury or cardiovascular events that some of these patients have, even if they did not have a pre-existing disease? Is this being considered in your management protocol? This sounds like somebody from your tribe.
Yes, so the answer
sounds
is
like
yes.
A physician.
The answer is yes. In fact, we're just going to embark on a study looking at cardiovascular complications in COVID. We don't know in our population what will happen. We know that they do get things what we call myocarditis, which is inflammation of the heart. But it's watch that space. We know there are complications, and we are looking after them.
Okay. So the next question is, why is there a lot of discrepancies in the way COVID is managed all over the world? E.g., why is it that some countries are less strict than others, like Tanzania, Sweden, Belarus, and others? Sweden basically opened up and everybody is going out and getting a burger or getting a coffee. In Tanzania, we saw the ferry crossing point still very crowded. So the question is, isn't there a standard? WHO keeps talking about all of these things. Why aren't we following these guidelines?
So it's interesting. I think governments make their own guidelines. Even the WHO has their guidelines. So Sweden was open. I think the US was open for quite some time, and we see what's happened to US and the UK, having been open for so long. And those are countries that could try it. We can't even try opening up because we don't have the bed capacity if we were to get a surge. So it's also what capacity the government has, the healthcare capacity before a lot of these measures are put in. And we're all watching Sweden to see what happens.
So somebody's asking a very interesting question. Are producers of daily consumer products like bread, milk likely to spread the virus to a huge number of people in the event the sales people are infected? So you go to the grocery store and they hand you produce. And, so is a person handling your grocery at the supermarket or giving you fruits at the market likely to contaminate your groceries with COVID?
So very interesting. So I think the big supermarkets here, as we know, as we walk in, we are given sanitizers and gloves and masks. You have to wear that. The question is the small markets. And I think the government is trying to do a lot of education there to explain to wash hands, clean everything. Very, very interesting. I think if we do get the surge and we get huge numbers, that will be one cause of spread.
So another interesting question is, and this is kind of a moral, ethical question. how do we protect homeless people, poor people, who can't practice all these things like social distancing, hand washing, hygiene, can't wear masks and all this stuff? Are we now creating some bifurcation here, which is almost an economic discrimination? That if you can't afford a face mask, if you can't social distance, if you can't shelter in place in a comfortable home, then you're just going to die.
So again, a very interesting question, and it's something that we've discussed with the government. It's just homeless. I can understand homeless is an issue all over the world. I think America has the largest number of homeless, and they're grappling with that. And they're an advanced economy with lots of money. So we have our homeless, but what we say is if you're 2 or 3 in a room, you live in a 1-bedroom flat, then you don't social isolate everybody isolates, so you isolate the home. So if you have one person who's infected, everybody doesn't go out. But of course, I mean, there is bifurcation of care. We know that. We live in the third world, and even in the first world, there's bifurcation of care. And this is where the governments need to come in a pandemic to say everybody's going to get equal care, or this is what we're going to do. These are hard times for governments, and they've got to come up with policies to make sure that the care received is equal for everybody.
So somebody's asked a question which you talked about, but I think maybe just for the sake of the person who's asking it, to be clear in their mind, how are the symptoms of this novel coronavirus different from those we associate with a typical common flu?
So the common flu, you'll have a mild cough, cold, headache, malaise, which you can also get in coronavirus. So what I'm saying is the symptoms of the URTI, the upper respiratory tract infection that we've been getting every year or every 2 years, the mild coronavirus symptoms are the same. For 70 to 80%, it's the ones that deteriorate, is the ones that end up requiring increased oxygen, cannot complete single sentences, cannot complete 1 to 10 in one breath. So it's very difficult to distinguish, and I think the US did find it difficult to distinguish between them before we started testing for SARS-CoV-2.
So here's another question which I think comes from somebody who knows a lot about this disease. It is known that the COVID-19 has affinity to ACE2. It helps it attach to the epithelium of the cells before it invades the cell. It is also known that children have an abundant ACE2 compared with adults. You would expect that the disease would be more severe and fatal in children than it is in adults, but it is the other way around. Why is this so? First, my question is it true?
So children, so the...
Is it true that children should are not being infected as much as adults?
Yes, we know that. So I don't know about being infected because we don't go out and mass test children, but in terms of severe diseases and requiring admission to hospital, children are way less than adults. Okay. So that we know. We know children have more ACE2 than adults. We again don't know why they don't have the severe disease. And then there's this whole thing in media because a lot of hypertensives take a drug called ACE2 inhibitor for blood pressure. But I think there's no evidence that you should stop taking it, that it doesn't increase your infection or decrease your infection. There's been theories on both sides. So in terms of your ACE2 inhibitor medication, do not stop taking it.
Okay, so any more questions?
Yeah.
So maybe we just ask them and Reena could take them.
Studies are just coming out showing 3 different strains of SARS-CoV-2. Would the vaccines cater for all strains?
If all the strains have spikes, yes, but like I was just telling Alex earlier, that we know that the influenza virus mutates. Every year we have a new influenza virus. We don't know how much it's mutated. So there has to be some genetic similarity between the strains for the vaccine to work. So if they mutate more than, I think it's 40%, then it wouldn't work. So that's what is being watched all over the world.
So would it suggest that there's a Chinese strain? Would there be a European strain? Would there be an Asian strain? Would there be an African strain? Yeah. Would there be a North American strain? But what we also know is that the populations, it was people moving from one place. The people who moved from Wuhan straight to Seattle, the people who moved to Wuhan through Asia, through Dubai, through Istanbul. The people went straight to Iran, and then that's the strain that is probably moving through Pakistan, Afghanistan. Then we have one that came through Kinshasa in Congo. We don't know whether that's the African strain because we have South Africa with all its connections. We have Kenya with North American and European connections. So I'm not sure whether we really have neat strains as yet.
I don't think there will be like a European American strain, like you said. I think there's too much travel and intermingling of populations. I think what I meant is when the virus multiplies, when these viruses multiply, there's an error. And sometimes when there's more of an error, then there's a different strain coming in. So that is what we're looking for, to see if the strains are differing or how much different are they. And that only time will tell us.
Yeah. Okay, the next one.
Can Africa afford to deal with the pandemic like the West is? And what should be done to better prepare for future pandemic outbreaks like this? That's from Marietta Selvin.
I think our governments need to put in more money into healthcare. I mean, our healthcare budget is abysmal. I mean, if we want to save people, we have to have the hospitals, we have to have the personnel, and we have to have the critical care facilities. If we don't have that would be difficult. So in future, I think, and I always tell the politicians, the days of going abroad to seek treatment are gone. You've got to get your treatment here. So develop your counties, develop your country. You can't leave. So yeah.
So there's another question which relates to some of the things we talked about, like the solidarity trial. And this is the question. There's a lot of negative and suspicious conversations being fed to the population in Kenya through social media regarding vaccines. What are the plans in Kenya to mitigate this, because it will have a huge impact on rolling out vaccines in the future for any diseases in Kenya?
So as far as I know, this vaccine trial is not yet. There's no commitment that's going to happen in Kenya.
Yeah.
So I think people need to be rest assured. Having said that, in sub-Saharan Africa, we probably have the best vaccine center. You know, we have Kavi, we have the best virologists. So if there was to be a trial, it should be in Kenya, because we are the leaders there. And every country, we don't know if it's tried out in Oxford, in Caucasians, whether it's going to work in Africans.
Yeah.
So we've got to do it in our ethnic population. But once the person has been given informed consent, they know what it is about, what they're going in for. So having said that, yes, I think Kenya is a great site. The Kenyan researchers are world class. And if it were to come to Kenya, they're the ones who would lead it. So they would make sure that it's not going to be given to anybody or every Kenyan. It's people, healthy volunteers, who are paid, who want to be part of it.
We available?
Yeah, we have about 9 minutes.
Okay. We have just about 10 minutes.
Okay, how prepared are we currently in terms of critical care? In brackets, ICU beds, say in Aga Khan. Have we been receiving more patients that require critical care after the first round recovery?
So we've had a number. We've had about 5 to 6 ICU patients in Aga Khan. So in Aga Khan we're managing, and there is the field hospital that's been planned. So I think in Aga Khan we have our plans. If there's a surge and we have an increased number of ICU patients, we will be able to deal with it.
Someone is asking about serum therapy.
Yeah, so that was the convalescent plasma that I was talking about, that you take the blood or plasma of a patient who's recovered 2 weeks after they've recovered, and if you give it to a compatible recipient, and it's been shown to work in other parts of the world. We haven't done it here yet.
Okay. What chances do we have that the coronavirus will end at some point, or is the disease here to stay just like HIV/AIDS?
We don't know that. So we know SARS-CoV-1 is not in circulation.
Yeah.
We know MERS, which is another coronavirus, like I said earlier, is still in circulation at a very low level.
Yeah.
So watch that space. We don't know. Having said that, the Spanish flu or the flu pandemic in the early 1900s is still around. It's just that we know how to manage it better. So I think the fear for COVID-19 will go down once we know how to manage the disease. In a sense, like HIV, we've learned to manage it, right? People don't die, there's ARVs, we know more about it. But that's 20 years down. We're only 4 months into the pandemic.
Yeah.
We don't know so much about it yet.
So the other question was, are there permanent effects of coronavirus on recovered patients? If you recover, you walk out of ICU, you go into a normal ward bed, and then a few days, weeks later, you walk home like Boris Johnson. Are you fine for life? Is there any other complications that might arise from that infection?
We don't know. We're watching that space, but it seems that the ones that have recovered are okay.
Yeah.
There is some literature that they may have some chest complications long term, but we haven't seen them yet.
Yeah. So, Prof, there are some reports supporting the combination of using Chinese herbs and conventional medicine in managing COVID in China. Have you heard about these? And what is your take on integrating traditional medicine in managing COVID?
So, very interesting. So having said that, let me take a step back. Our main treatment for malaria, which is artesunate, is a Chinese herb. So it came from China as a herb and it's now mainstream. I think a lot of herbal medications do make it into mainstream allopathic medication, but it has to follow trials. There has to be evidence-based that it works before we say it works.
Yeah. And then the other one is, how will COVID change medical and health protocols related to travel?
Interesting. In the short term, I think people are going to have the test before they travel. There's going to have you're going to have a COVID test.
Like an immunity passport or something.
Yes,
like that.
there'll be something like that.
Yeah.
Yes.
Yeah. And then quickly, as we see we're running out of time, what nutritional interventions do you advise?
What you advise anyone who's been unwell: eat healthy, fruits and vegetables, home food. Interesting, people have been eating at home, so we're not seeing so much diarrhea at the moment and vomiting.
Yeah. So somebody suggests that so many people have recovered and again got infected with COVID. Why didn't the antibodies protect them? And how can antibodies of such recovered people help other patients?
So interesting question.
So have we seen cases of reinfection?
So it's a Hong Kong or Singapore, one of the Korea, South Korea reported that there have been rates of reinfection. So now people are looking at their initial testing,
Tests,
repeat tests to see.
Yeah.
We're watching that space. A very interesting question.
Yeah. So somebody's asking, you can be testing in the morning, you're negative, and you get contact with a COVID person in the evening. How does testing help?
So like I said, the virus goes and replicates in your respiratory epithelium, your mucosa.
Yes.
And that's how you get your stuffy nose and you get all those symptoms. So you need a certain number of virus to pick it up. So when you do your nasal swab, if you're asymptomatic and incubating the virus, we may not pick it up. So that's why initially the government was saying we test only symptomatic people, because your likelihood of picking up is higher and your false negative is lower.
So it's also good use of resources.
Yes.
Yeah. With the opening of restaurants, don't you think this might lead to spiking of cases?
Yes, we're worried. I mean, I know the government has put in measures that you've got to have that distance, you have to have the masks, the waiters or the people working in the hotel have to be tested. So there are measures that have been put in, but we're watching that space. Yeah, so
the other question, they're coming fast and furious, these questions. Can I be asymptomatic until I recover and overcome the virus?
Yes.
Oh, really?
There have been people, there are reports that people who've not had them and they've had swabs and they're positive, but they're asymptomatic.
Until they're just fine, until test negative.
Yes, test, yes.
Wow. So this is really more about people's bodies than the disease. And this is really curious for a viral infection of this scale. So I guess we're kind of running close. So I'd like to ask you, Reena, to just what are some of your parting shots and what does this mean in the future? Is it possible that we will go to a pre-COVID normalcy? Shake hands and sing Kumbaya again, fill up our churches, mosques and temples, have a great life in restaurants and Nairobi's very active social life. Is this the end of that?
Yeah, so I've been thinking about that as well. Having said that, there was a pandemic 100 years ago where people stopped going to church, temples, people walked around in masks, and there are WhatsApp images of that going around. And then those countries went back to normal. So we know about 20% of the world's population died at that time. Whether we'll go back to normalcy, I hope so. I think it'll take time. I think we've got to learn more about the virus. If we get a vaccine, if we get a treatment, then I think it'll be sooner for us to go back to normalcy, but I'm sure it will happen. What I don't know is the time frame, how long it will take. In the meantime, I think what we do know that social distancing helps. We know washing your hands helps, cleaning your surfaces helps, all the normal things that we should have been doing, that we stopped doing. That helps. Social distancing is physical distancing, so you stay away from somebody, but do not stop to connect socially. We're social human beings, we're social animals. We need to talk to people, we need to interact with people. That shouldn't stop. So look at us in 1 month. We have Zoom calls, we have CMEs online, we're talking to people a lot. Families are sitting down at home and doing things together. The other thing I do want to say is keep hope, humanity's come through a lot of things and we will survive this as well.
Yeah. So one last question was, initially when this started, everybody was talking about how Africa was going to be pummeled by this disease. We didn't have enough ventilators. We don't have enough ICU beds. Our critical care capability is not up to scratch. Now it turns out that the outcomes from patients who've been intubated is not that great. And their ventilators are not really the silver bullet. They're not the savior for a lot of the patients, and the outcomes have not been as great. What are your thoughts about this as somebody who is intimately connected in this world?
So I think the studies are looking at trying to put in measures so that the patient doesn't get to ventilation. So a lot of these medications, these trials, are giving medicines to prevent patients getting to the ventilator point. Having said that, we know the mortality is high. It's about 60%, 60 to 70% once you're on the ventilator. But even then, 30% survive. In critical care, we know a lot of people who go to ICU for whatever reason, even if it's not COVID-19, we know their outcomes are poor. Yeah, so that's been there. But I think as long as you have hope, and if we can understand that when they're in the ICU, what tips them over, whether it's a cytokine storm or whatever, if we can put measures in there to reverse it, then hopefully our outcomes will be better. But like I said, we just keep learning every day.
So thank you very much, Reena. Our colleagues watching and listening from all kinds of places. As you can see, this is a steep learning curve for all of us. Physicians or critical care colleagues have a lot to learn, just as much as we do as well, to learn about the disease, to learn how to listen to our bodies, to figure out when to seek help. And now there's telemedicine. Don't show up at a hospital just for a random question. Call your physician if you can. Get some advice on what measures you should take. But I think what is most important is that in the absence of cure in terms of drug therapy or a vaccine, all we have is to escape infection, non-pharmaceutical interventions, social distancing, using facial masks and all of that. And for our governments, I think contact tracing, isolation, those are the critical measures that we have to take to basically bring this reproductive number to less than 1 and then begin to stem the tide of the surge of this disease. So thank you very much. We will be back next week on another different conversation on the series Understanding COVID-19. So stay tuned. We'll get back to you the details of the topic, and the next speaker is going to be just as inspiring and as brilliant as Professor Reena Shah. So thank you very much, Dr. Tari.